Okay, cardiac tests. Moving on to the heart. Laboratory tests for myocardial infarction. With cardiac testing, we need to differentiate between two different things. We need to know what test to do if there's actually been a heart attack, if there's actual damage to the myocardium, and then we need to know what test to do to evaluate the risk of having a heart attack or cardiovascular disease. Electrocardiogram, ECG, or EKG. This is a test for an MI. There's a limitation to an angiogram. It's possible to have significant plaquing throughout and still have a normal angiogram. If there's blockage, the artery kind of opens up some and our lumen stays the same. Most useful direct test, 50% will show changes, but this implies 50% don't show changes, so it's not definitive. Leukocytosis, even though not inflammation, our white count goes up because our immune system is going to go into high gear, even if we don't know what it is, even if it doesn't have anything to do with an immune attack. It begins 12 to 24 hours, so within the first 3 to 4 hours, it may not show up at all. So again, we may not be able to tell. It lasts a couple weeks, then it goes away. So if someone has sharp chest pain, diaphoresis, all that, but they don't go in, after a while it starts feeling better, then 3 to 4 weeks later they come in and get checked out, it may be too late to show anything at that point. ESR, common AKA is sed rate, marker for inflammation, heart muscle that is damaged, you'll have inflammation, goes up with leukocytosis. You might be able to see on a radionuclide heart scan if there's been a heart attack. Just FYI. AST, spartite aminotransferase, liver enzyme, but also in the heart, much more than ALT. So if raised without ALT, GGT, those kinds, we'd consider this a marker for heart issue. Released from necrosed cardiac muscle. Necrosed means dead from infarction. But it goes back to normal, and it's not specific. It's elevated with other things